name is Tamika. I'm here to go over the anatomy of the eye as well as some eye conditions that we would see in older adults as well as our geriatric community. This is for my adult health one. So now I just want to get right into it. So this is my anatomy. This is my diagram of the eye. So on the outer layer, we're going to have the sclera. That is going to be what we know as the tough membrane. It is also known as a protective membrane. Okay, it protects the eye. On the also on the outer layer is going to be our cornea. The cornea is going to also protect the eye, and that also prevents like any foreign bodies or objects from coming into the eye. The next one will be our middle layer. In our middle layer, we're going to have our choroid, and the choroid is which brings in the oxygen as well as the nutrition into the eye. So that's our choroid right there. Okay, the next one we're going to have is going to be the most important part of it, and that is our retina. Our retina is the inner layer. That's our innermost layer. It has two layers to it. It's going to have the hyperpigmented, highly pigmented, and the neural layer, which consists of the rods and the cones. Now, in the rods, they are sensitive to dim light, dark light. So in that setting, if there's dim or dark light, our pupils are going to dilate. And then if the cones are going to be sensitive to more of a light or bright light. So with that case, if we're in a bright light, or if you even shine a bright light in your eyes, your pupils are going to constrict. And so going into that, we also got the iris. So the iris is very important. That is what determines what color our eyes are. So if you see someone who has green eyes, that means their iris is actually going to be green. The iris acts as a camera. It controls the amount of light that enters into the pupil. Now, what is the pupil? The pupil is going to be the hole that goes right through the center of the iris. In order for, excuse me, I'm sorry. And the iris and the pupil is where the light comes right through into there. Now, in order to see clearly, the retina will have to allow the light to come through. The retina contains light-sensitive cells, which turns into electricity. Those electricities go through the optic nerve, and they will go up to the brain to send messages to process information. As we stated, the cornea is going to be the outer part of the eye. However, in between the cornea and the lens, in between the outer part of the eye, which is the cornea, and the lens, this is our lens right here, we're going to have the aqueous humor, which is going to be a watery liquid. And it's a very transparent liquid. Now, in the space between the retina as well as the lens, we're going to have vitreous humor, which is going to be more of a jelly-like substance that maintains the shape of the eye. Okay, the ciliary muscles. This is going to be the ciliary muscles. Now, these are very important because they can change the structure of the eye. If objects come really close, the optical power of the ciliary muscles, they're going to have to bend more. If objects are further away, the optical power is bend less. So now I want to go into our conditions, and in our conditions, I want to start with macular degeneration, which is most common irreversible central vision loss in people who are 60 years old or older. Two types are atrophic, which is most common, and the other one is what we call wet, which is a exudate, which is the more severe kind. AMD, or age macular degeneration, is related to retinal aging. The risks happen to be family history, light-colored irises. The patient may have blurred, darkened vision, or blind spots. Acute vision loss is actually common. What tests would be done? The visual acuity measurement, ophthalmoscopic exams, the Amster grid. Also, we will want to avoid giving the patient the impression that there's nothing that can be done, although therapy will not recover the loss of vision. Retinal detachment, separation of the sensory of the retina and underlying pigment epithelium with fluid accumulation between two layers. If this is left untreated, it's highly likely that blindness will occur. The risk of course, aging, eye trauma, family history. Once there is a retinal break, liquid from the vitreous humor may leak in between the layers, causing detachment. In that, what happens? What do we expect? Light flashes, floaters, cobweb vision, around like vision. That's what the patient may experience. We're going to test it through direct and indirect ophthalmoscopy, slit lamp, test ultrasound to see if the detachment has occurred. In most cases, it's urgent. We want to give the patient the prescribed medication and promote the use of protective eyewear. Glaucoma increased intraocular pressure, which causes optic nerve atrophy. Peripheral visual field loss. Patient usually doesn't know until it's a tunnel vision. Sudden severe eye pain, vomiting, blurred vision, and colored halos are some of the symptoms that the patient will experience. IOP measurement with tonometry. Field visual acuity, measurement and visual field parametry. Those are some of the tests that will be done. Require long-term management. Assess the patient's ability to adhere pain. Encourage the patient to set up medication schedules. The patient must comply. No progression or visual impairment will occur. The next is cataracts. The patient may have cataract is an opacity within the lens or are one of both eyes, causing a gradual decline in vision. Most commonly in geriatric or older adult population, altered metabolic processes within the lens cause water accumulation and change the lens structure. Well, with the cataracts, there is no treatment except for surgery that can repair this. Diagnostic tests are the lens opacities, the lamp microscopic or visual acuity. The patient may have decreased vision, abnormal color perception, and glare. Hyperopermy, which is also known as farsightedness, unable to see objects that are near but can see objects that are far away, occurs when the cornea or the lens does not have adequate focusing power. And then the last is loss of accommodation, common with aging, which is the presbyopia. Usually symptoms are appearing more in the mid-40s. As eyes are aging, lenses become larger, firmer, less elastic, inability to focus on near objects. Then this can be corrected with lenses or contacts. Thank you so very much for participating here in my presentation for the anatomy of the eye and my conditions of the eye. Thank you. Have a great day. What am I?